Thank you. Thank you so much for having me here. I'm honored to be here to kick off this afternoon session and talk about immunizations in patients with immune-mediated inflammatory diseases and immunocompromised patients. And in the era of COVID, there's a lot we could talk about here, and really many different immunizations, including COVID vaccine, which we'll of course talk about at the end. But I hoped to give some highlights and updates in key things to know about protecting our higher risk patients or patients with immune-mediated inflammatory diseases, or IMIDs in particular, against influenza, pneumococcal disease, herpes zoster, and of course SARS-CoV-2, and what are special considerations in this special patient population. So I'm gonna, in the short time I have here, hope to go through these highlights and save some time for questions at the end, but starting with influenza. So patients with immune-mediated inflammatory diseases are at higher risk for getting flu and higher risk of having complications from the flu, so severe disease, hospitalization, et cetera. And also these patients have risk of prolonged viral shedding. That depends on what medications they might be taking, in particular systemic glucocorticoids, and this is something we have learned is true for SARS-CoV-2 as well. So protecting against seasonal influenza is very important for everyone, and in particular this group for these reasons. And we know that vaccination is both clinically and serologically effective in IMIDs patients on a variety of different immunosuppressive therapies. So before I dive in, you may have heard that this season's flu vaccine was kind of a swing and a miss. Very low vaccine effectiveness, which is not at all surprising given we didn't really have a flu season last year or the year before that because of pandemic precautions. So this year's flu shot is very ineffective. I've seen 10%, 20%, especially with the current circulating main strain, which is an influenza A. So while we say every patient should get a flu shot every year, if there are patients now that still haven't gotten their flu shot this year in particular, there's been some vaccination fatigue, and that might be okay. But they'll be back at it next year because we do have a flu season this year, and they base next season's vaccine off of current season strains. So who should get a flu shot? Everyone should get a flu shot. Doesn't matter formulation outside of age recommendations, for which 65 and older should get a high-dose flu vaccine, but there are many, many different flu vaccine formulations. There's adjuvanted, trivalent, quadrivalent, egg-based, cell-based, and the CDC has a nice list and review of all these different formulations, and you don't really need to remember them. And typically, during a normal flu season, we recommend administration by the end of October. This is a really important point, flu shot for egg allergic patients, because like me, I'm sure you've had many patients give this reason of why they haven't gotten a flu shot or why they don't get vaccinated against the flu anymore, because they're allergic to eggs. So for the past several years now, the guidance is that anyone with any kind of egg allergy can receive any flu shot formulation, and that includes a mild, moderate egg allergy and patients with severe allergy, including anaphylaxis. So they can receive any flu shot formulation, including egg-based flu vaccines. So this is no longer a reason to not give a flu shot, and a lot of people don't know about this, so important to always ask your patients who say no, why, and then you can educate them and tell them that things have changed and it's safe for them to get a flu shot. This optimal timing of administering different vaccines in the setting of various immunosuppressions is an important topic because there's some things to consider here, and it varies depending on what immunosuppressive drugs your patients might be taking. And I share here a table from a recent, very nice review by Marcia Friedman, Jeff Curtis, and Kevin Winthrop that goes over what we know about impact of various targeted therapies on humoral response to various vaccines. And this includes COVID vaccines over on the right, which I'll talk about more at the end, in particular what we know about impact of drugs we use on immunogenicity to COVID vaccine. But what we know very well for a long time from data on flu vaccine and pneumococcal vaccines is that methotrexate reduces immunogenicity to those vaccines, and Rituximab and other B-cell depleting drugs is the worst in this regard. If you vaccinate someone against influenza or pneumococcal or COVID, which we'll talk about, within the 6 months after Rituximab infusion, they're not going to have a response. A very, very small proportion of those patients will have a humoral response to those specific vaccines. So things to consider there, including timing as best you can around Rituximab, where we recommend waiting as long after their last infusion and then 2 to 4 weeks before receiving their next Rituximab infusion to vaccinate against flu, pneumococcal, or SARS-CoV-2. Methotrexate, I'll share some data on the upcoming slides. As you can see, there are a little bit of data on abatacept, reducing both humoral and cell-mediated immune responses to certain vaccines, although clinical significance is unclear. But methotrexate and Rituximab are the absolute worst. I share this because this is kind of a pivotal study that is practice-changing in some regards. This is Kevin Winthrop and colleagues did this study asking if you hold methotrexate for a period of time after seasonal influenza vaccine, does that increase immunogenicity? And they did this study in patients with rheumatoid arthritis that had very stable disease, so a very well-controlled group of RA patients, and they compared not holding the methotrexate versus holding it for 2 doses after they received the flu shot, and did find a significant increase in immunogenicity. This paper is now several years old. There are people that are on both sides of this fence. I happen to think this is something that should be discussed with our patients, at least for, depending on the patient and their disease activity and, health beliefs, at least for them to know that there is potential to have increased flu vaccine response if they are comfortable holding their methotrexate. Of course, this isn't for everyone and might not be extrapolated to other diseases depending on extent and organ involvement, such as lupus. But this is important information and something that I do talk about with my patients. Of course, there was a slight increased risk in flare after holding in the hold group, but was not overly clinically significant. So summary, flu shot for every patient every year. Maybe not this year, but next year. Patients 65 and older should receive a high-dose flu shot. And in patients with quiet inflammatory arthritis or psoriatic disease, consider at least talking to them or holding methotrexate after seasonal flu. And we'll come back to that in regards to COVID vaccine at the end. I'd like to spend a little time on invasive pneumococcal disease in particular because the vaccine recommendations recently changed and went from very confusing to slightly less confusing. So I wanted to summarize and walk through them. But strep pneumoniae is a huge cause of bacterial pneumonia and other severe infections, other invasive pneumococcal disease, meningitis, et cetera. And mortality, especially in patients with IMIDs, is high, and they're at increased risk of getting invasive pneumococcal disease. So we have vaccines to prevent, and so this is important to be aware of. As I said, the guidance is a little confusing and has changed many times in the recent past. So these are kind of, just glance briefly, because these are the old recommendations. There were 2 vaccines, a conjugate vaccine, 13-valent conjugate vaccine, or Prevnar, and then a polysaccharide vaccine, or 23-valent vaccine Pneumovax, and depending on immune status, immunocompetent versus immunocompromised, the age at which you get the vaccine, and which vaccine you get first, the recommendations for order of vaccine is different, and that's incredibly confusing. But the recommendations for immunocompromised patients are to do this prime boost strategy, where in a perfect situation, you would get the 13-valent conjugate vaccine and then sometime after the polysaccharide vaccine. But as you can see, that was set up for a lot of confusion and led to a lot of people not getting the right series and sequence and being behind on vaccine recommendations. So this is kind of the journey of the recommendations and how it got so complicated. Just briefly, in 2012, the ACIP, or Advisory Committee on Immunization Practices, recommended that 13-valent conjugate vaccine be given in series with the polysaccharide vaccine in a variety of immunocompromised persons. And then this was extended to all adults 65 and older. And then 3 years ago now, they actually removed the Prevnar recommendation for 65 and older to be made with shared and clinical decision making. So not necessary for everyone 65 and older if they're immunocompetent. And that's for a lot of reasons. Invasive pneumococcal rates have gone down in older adults for several reasons, but mainly from increased uptake of childhood vaccinations. But as you can see, this was confusing. So what do we have now? We have 2 new vaccines, which are expected to phase out the conjugate 13-valent vaccine. And these were both authorized last summer. There's a 15-valent conjugate vaccine and a 20-valent conjugate vaccine, Prevnar 20, and they each include serotypes included in PCV13 plus the appropriate number of additional serotypes that are felt to cause the vast majority of invasive pneumococcal disease in immunocompromised persons and older adults. So these are more simplified, and here are the recommendations. Lots of decision making was removed, and so there's only 2 things you need to think about if patient is 65 or older, regardless of immunocompromising status, or if they're 19 to 64 with this laundry list of comorbidities or immunocompromised iatrogenically, and IMiDs patients on a variety of immunosuppression. So they should get either just one of the PCV20 or PCV15 followed within a year by Pneumovax. So now this new conjugate 20-valent vaccine has replaced all the other vaccines. And we at the Cleveland Clinic now have PCV20. So if you're meeting a patient who you're going to immunocompromise or is immunocompromised or has another one of these risk factors and has never been vaccinated against pneumococcal vaccine, you can just give them the PCV20. And if they've received one of the older vaccines in the past, you have to do a little bit of thinking. That's summarized here on this table. But it might not seem a lot clearer, but it is more simple than the previous recommendation. So hopefully that made sense. Moving on to herpes zoster, of which in IMiDs patients and immunocompromised patients, there's tremendous burden of herpes zoster. We all know that the incidence of zoster increases with age. This is the #1 risk factor, but our IMiDs patients have increased incidence even at very young ages, depending on their disease and what targeted therapies or steroids they might be on. And herpes zoster has potential to lead to a lot of complications, the most common of which is post-herpetic neuralgia, which can carry with it significant morbidity and more serious complications such as stroke and other complications that are not preventable with the antiviral treatments, which aren't extremely effective in the first place. So prevention with vaccine is preferable, and we have a very effective vaccine against shingles, the recombinant herpes zoster vaccine, or Shingrix, which is a non-live recombinant subunit vaccine, which uses a novel adjuvant that is very potent and is the reason for its significant reactogenicity, which I'll touch upon, but it is a novel adjuvant system that uses a saponin from the Chilean soapbark tree combined with a detoxified derivative of lipopolysaccharide from a Salmonella bacteria. So really stimulates the immune system, and its approval is based on 2 pivotal studies, Zoe 50 and Zoe 70 for the respective age groups. And this vaccine is over 90% effective at preventing shingles over a very durable period, which is different from the live zoster vaccine or Zostavax, which we don't use anymore, whereas efficacy was closer to 60%, and about 5 years after a patient receives live zoster vaccine, the efficacy wanes to as if they never received it in the first place. So this is really impressive efficacy that is durable, and even in patients 80, 90 years old, so not significantly affected by age, who are older patients are the most vulnerable. So this is now the preferred shingles vaccine, which initially was recommended for 50 and up. Important to note is it's recommended for people regardless of history of shingles. Many patients will say they don't need this vaccine because they already had shingles, but shingles can happen as many times as their immune system would like, and that incidence increases with age. And also recommended if they have had the live zoster vaccine in the past, they're still recommended to get this vaccine. And last summer, live zoster vaccine was removed from the recommendations, and all available doses have expired. So there's no live zoster vaccine available in the United States, but in other countries, this is still widely used, and we are one of the only countries that has great access to the recombinant zoster vaccine. So still important in other parts of the world, the live zoster vaccine. Perhaps most exciting is that last summer, recombinant zoster vaccine got FDA approval and ACIP recommendation to give to immunocompromised persons 18 and up, which makes a lot of sense because we have a lot of data to show that patients with IMIDs, even starting as young as age 18, have higher risk of zoster compared to immunocompetent 50-year-old, which was the original recommendation. So the need is there. This is also recommended by ACIP. This was largely based on studies in cancer patients and transplant patients, and a couple in HIV patients that showed it was safe and effective and very cost saving as well, because of the huge burden of shingles and post-herpetic neuralgia mainly. So this is very exciting. It has taken some time for insurance companies to pick up on this, but they're starting to. Does everyone 18 and older with an immune-mediated inflammatory disease or on immunosuppression need Shingrix? Probably not. Based on disease, based on targeted therapy, I'm not talking about this in this talk so much, but JAK inhibitors are the huge outlier of risk of zoster, significantly increased risk. So this is probably the biggest group of younger patients that we talk about vaccinating against shingles too, because we know their risk of shingles over a lifetime is very high. A couple more tidbits on Shingrix. It is important to counsel on potential for reactogenicity, somewhat similar to the reactogenicity or local and systemic side effects we see secondary to the adjuvant and the revving up of the immune system is somewhat similar to what we see with the COVID mRNA vaccines, but very high incidence of transient potential for significant reactogenicity, usually the day or two after this vaccine. So I tell patients not to get this the day before a big activity or a wedding or something like that. And there's a decent chance they might not feel very well. This next bullet is important because now with the new recommendations and younger age group for which this vaccine is recommended, we're talking about some patients who might never have had primary varicella or chickenpox, or might not have been vaccinated against primary varicella, and like, what does this mean for that group? So over almost 100% of persons born before 1980 had chickenpox. What's recommended now, if patient doesn't, remember, and you're talking about do they need Shingrix versus primary varicella vaccine, what counts as documented immunity is if they did receive primary varicella vaccine, so the vaccine against chickenpox, Varivax, which is 2 doses in childhood, if they have lab evidence of having had chickenpox, so a VZV IgG is very easy to check, or if they have a documented history of presenting with clinically chickenpox or zoster by a healthcare provider. And if they don't have any of the above, they don't need Shingrix, they actually need primary varicella vaccine, which can be challenging depending on the patient and immunostatus. That is a live vaccine. Shingrix is not intended to prevent against primary varicella, although it is being looked at for just that purpose right now. So stay tuned. A couple slides on some of our data from the Cleveland Clinic, because given the potent adjuvant, and of course in any early vaccine trial, patients with IMiDs and immunocompromised patients were not included in those pivotal trials, and there was theoretical concern for flaring autoimmune disease after Shingrix. So we looked at 350 patients with IMiDs in our department and followed them for flare after both shingles vaccines. And we found that 16% of them flared. Most of our population was rheumatoid arthritis, and they had the most flares, not surprisingly. And interestingly, in a third of patients, flare occurred in a temporal relation to a treatment change, meaning on the day the patient got their shingles vaccine, they were also having a change in their treatment, whether it was a prednisone taper, changing their methotrexate dose, or switching biologics, which signified to us that if that perhaps represented active disease. In that case, that might not be the best time to vaccinate someone against shingles to lower the risk of flare. And in this Cox model, being on steroids at the time of vaccine was also associated with a flare, again, going with the notion that having a flare, active disease, is probably not a good time to give shingles vaccine. If you can wait till next time, it's probably a good idea. It makes sense. Last but not least, vaccination against SARS-CoV-2, which we, of course, could talk about all day, but there's some considerations in IMiDs patients and in certain immunocompromising drugs that we use, and in particular, which drugs affect immunogenicity against COVID vaccine. First, this is the National Psoriasis Foundation COVID-19 Task Force guidance statement. This is led by Chris Richland and Joel Gelfand and was created very early in the pandemic, and I was fortunate to be a part of, and has tried as best we can to stay up to date on guidance, best practices, and recommendations for providers and patients about prevention and treatment of COVID. So it goes over, up-to-date recommendations on vaccines and treatment, and in this document, there is no guidance to hold any medications around COVID vaccine, which is a little different than our ACR guidance document, but no one's wrong. No one's right. We still have a lot to learn in this regard. But what we do know is this is a early study, one of the bigger early studies looking at negative impact of various targeted therapies on humoral vaccine responses. This was done by Al Kim and colleagues at WashU. And the takeaway is that B-cell depleting therapy gives the biggest negative impact to humoral immunogenicity, 36-fold reduction in immunogenicity, which is huge and has been replicated many, many times. And clinically, B-cell depleted patients do just terrible with COVID despite being fully vaccinated. Steroids, not great. JAK inhibitors, maybe okay. Mycophenolate, slight reduced reduction. No significant impact from hydroxychloroquine, TNF inhibitors, fortunately. My last couple slides, as I mentioned, Rituximab, this is really the outlier. This is a rough drug for our patients to be on now. Given what we've learned about severe outcomes with COVID, we actually now really think twice about starting patients on Rituximab if there's another option because of what we have learned here. This study looked at predictors of responding to COVID vaccine in patients on B-cell depleting therapy. Most of them had IMiDs, some had cancer. Things that might be helpful and takeaways are the longer the time has been since their last Rituximab infusion, 7-8 months. If they have detectable B cells, so checking a CD19, this CD4 cutoff, all of these were predictive for vaccine response. But if you see over here, there are many patients in the study that had B cells at time of vaccine and still had no response. So now I'm not talking about Evusheld today, but we give all our B-cell depleted Evusheld when possible, because vaccine is just not helping them out very much. This is my last slide, or second to last slide. This is really interesting. This is by Andy Laster and colleagues who looked at a large group of patients with IMiDs on methotrexate, JAK inhibitors, rituximab and abatacept, and looked at humoral immune response in patients that continued drug versus held their drug or timed their vaccine around drug, like rituximab, for example. And what they learned is that holding JAK inhibitor after COVID vaccine did not impact or improve humoral immune response. Neither did holding methotrexate, and neither did timing vaccine around rituximab or abatacept. So we have a lot to learn there, perhaps reassures us and kind of confirms what we know from other studies, that JAK inhibitors are unlikely to have big negative impact on vaccine immunogenicity, and that we really need new strategies to vaccinate and protect B-cell depleted patients in particular. This is what we recommend for immunocompromised patients. These recommendations from CDC and beyond have been very confusing and change. It really seems by the minute, but now mRNA vaccines are preferred for our patients. If they got of J&J vaccine, it's recommended to complete their series with mRNA vaccine. Immunocompromised patients should have 3 doses of an mRNA vaccine. This is considered their standard of care. That 3rd dose is not their booster, it's their 3rd dose. They should have a 4th dose. Most patients, depending on level of immunocompromise, should have a 4th dose. And now there's this 5th dose recommendation from this week. There's really not a lot of data here. I am not telling any of my patients to go chase after getting a 5th COVID vaccine. And what we do know is that patients who've been fully vaccinated, at least with 3 vaccines, and had COVID, we call that hybrid immunity, and have learned it's very strong and durable. And I don't tell those patients to chase after a 4th vaccine either. But it's very confusing. Every patient is different depending on their disease, other comorbidities, and drug, and whether or not they had COVID. So clear as mud, but we'll learn more about that 5th vaccine recommendation. As with all vaccines, every patient, you'd be surprised at how impactful just taking a moment or two to, we all have vaccine recommendation and argument fatigue, just to check in with your patients about vaccines, ask in a kind way why they haven't been vaccinated, and address their fears and concerns and give them the right information. Even just a couple minutes can be helpful. These are my take-home messages. Assess vaccine status at every visit. Be aware of these drugs that might negatively impact vaccines, and counsel your patients accordingly. I'm not sure I left any time for questions, but happy to take few if I did.
Thank you, Cassie.
Thank you for that kind introduction, and for allowing me the opportunity to speak alongside so many experts today. I'm very flattered. So, as Dr. Fernandez mentioned, I will be speaking today on adjunct therapies to optimize response to targeted immunologic treatments. I have no disclosures, but I will be discussing off-label uses of medications. So the objectives for today's talk are to summarize the literature in Rheum derm diseases regarding adjunctive therapies, specifically with a focus on those conditions seen by both specialties, and also those in which combination therapies are not yet standard of care. Secondly, I will try to highlight clinically relevant scenarios where their combination use could be considered, and finally, to touch on safety data when available. So, rather than a mad world, Today, we find ourselves practicing in a mAb world filled with an increasing number of targeted therapies for inflammatory skin and musculoskeletal disease. So the question is, where does this talk fit into this world? Well, despite this increasing therapeutic arsenal, we still have decades of provider experience with traditional therapies that should be used. Secondly, as more of these targeted therapies have come onto the market, there is increasing data about its use in combination, particularly when targeted therapies alone are insufficient. And finally, as we know, these medications are not cheap, so trying to optimize their efficacy is really paramount as clinicians. So most of this talk will be focused on clinical efficacy data, but one important issue to keep in mind is immunogenicity. While this idea has been better described in the IBD realm, there is literature in the Rheum Derm world describing that anti-biologic antibodies can dampen clinical response. So the question is, what is the role of concomitant immunosuppression with these biologics? So this has been shown to decrease infliximab infusion reaction rates, also to decrease antibody formation, as well as potentiate response to biologics, with an overall reassuring safety profile. So the key questions to keep in mind as I run through these medications are, in which patients could these combinations be considered, and what do we know about their efficacy and safety? So we will start off with methotrexate, which far and away has the most supportive literature. So looking at psoriatic arthritis, the data regarding clinical efficacy when combined with anti-TNFs is somewhat conflicted. There have been numerous small studies showing that there is no increase in clinical efficacy when methotrexate is combined with TNFs. However, a large registry study of over 15,000 patients did find improved remission rates when methotrexate was combined with infliximab and adalimumab, but not etanercept. Switching to thinking about immunogenicity, the data has shown us that the use of methotrexate does increase retention rates of anti-TNFs, specifically infliximab. So outside of the TNF family, smaller studies, including this analysis of around 450 ixekizumab patients, found that there was no significant difference in efficacy when combined with methotrexate, which suggests that there is some degree of variability in the response to combinations depending on which biologic is used. Fortunately, this combination was well tolerated, even if it wasn't efficacious. So switching to psoriasis. Overall, the literature is more supportive than in psoriatic arthritis of increased clinical efficacy when methotrexate is combined with TNFs. Data for both adalimumab and infliximab have shown improved PASI scores in patients when methotrexate is combined. And as this graph demonstrates, an analysis of nearly 500 etanercept patients were compared on monotherapy versus combination with methotrexate, and the combination patients had significantly improved rates of PASI 75 scores. Importantly, it should be noted that the doses of methotrexate used across these studies is variable, with most of the reports ranging between 7.5 and 15 milligrams per week. This combination was generally well tolerated, with similar adverse event profiles between monotherapy and combination. So considering immunogenicity, as with psoriatic arthritis, the literature has shown a benefit to combining anti-TNFs with methotrexate. As I mentioned at the outset, anti-drug antibodies can limit biologic response, as seen in this study of 29 psoriasis patients, which graded their clinical response based on anti-adalimumab antibody titers. This study found that high titers were particularly problematic for clinical response, and those patients who were on concomitant methotrexate did not develop high titers. They also noted that the vast majority of patients who developed antibodies did so within the first 6 months of therapy, and those who were given increased rates of adalimumab did not have as efficacious of a response as those who had not formed antibodies. This additional study, looking at infliximab, also found some loss in clinical response when anti-infliximab antibodies were formed. Fortunately, the subsequent addition of methotrexate did lead to PASI reduction in these patients. Admittedly, the study did find increased rates of hepatitis in patients on combination, but they also had decreased infusion reaction rates. Another patient population who may benefit from adding methotrexate are those with TNF-induced psoriasis. Although there has been some conflicting data published, in a review of TNF-induced psoriasis patients who were continued on their TNF, methotrexate was shown in half of cases to lead to clinical improvement when it was used, and importantly, doses of 15 milligrams or more per week were more efficacious. So switching over to RA, while the combination of methotrexate with anti-TNFs is well established in this patient population, as mentioned earlier this morning, there is a lot of data as well regarding its overlapping use with JAK inhibitors. While an analysis of around 1,100 patients found that tofacitinib combined with methotrexate was non-inferior to methotrexate combined with adalimumab, a similarly sized study looking at baricitinib actually found its combination with methotrexate to be more efficacious than combination with TNFs. And furthermore, this combination in general appeared to be a safe option. So turning our attention to atopic dermatitis. Unfortunately, the strength of the literature here is less impressive. However, a study of nearly 70 adult patients who had an inadequate response to dupilumab alone did find improvement in their methotrexate added cohort, including the downtrending EASI score that you can see depicted here, without increased adverse events. Its use has also been reported as a safe bridging therapy when patients are starting dupilumab. Finally, methotrexate has been shown to be an efficacious and safe addition to infliximab in both hidradenitis and pyoderma gangrenosum, even improving clinical response and infliximab retention rates in patients who had already developed infliximab antibodies. Although rare, there are also reports of its use combined with adalimumab to improve both the joints and the skin in Sappho syndrome. So coming back to our key questions, the most robust data supports concomitant use of methotrexate with anti-TNFs, specifically infliximab and adalimumab, across multiple inflammatory diseases. While the early addition of methotrexate should be considered as antibodies can develop early, it can also be added after these antibodies have developed with good response. It can be used either as a bridging therapy or add-on with dupilumab patients, and also combined with JAK inhibitors, specifically in RA. Its role for efficacy in psoriatic arthritis is debated, but it does increase biologic retention rates. And finally, overall, methotrexate is the most well-established adjunctive option and a safe treatment for most patients. All right, switching to phototherapy. In psoriasis, multiple studies support the added benefit of phototherapy in combination with biologics, most commonly the TNFs. All of this provided that they are actually adherent to their phototherapy schedule. Specifically, multiple split skin studies, including in combination with ustekinumab, have found the combination to be both well-tolerated and to accelerate clearance of lesions at biologic outset. Here, you can see the changes at weeks 6 and 12 in patients in whom split skin phototherapy was added to adalimumab. If you look at the far left panel, on the top, you can see the treated side, which is pretty much clear of psoriasis, and on the bottom, the untreated side still has numerous active psoriatic plaques. Similar, small, but positive literature exists in combining phototherapy with dupilumab in atopic dermatitis. A randomized controlled trial of 45 patients found that the combination therapy had more rapid improvement in both clinical and symptom metrics at 4 weeks compared to dupilumab alone. The differences between the cohorts did become less significant over time, suggesting that this could be a helpful adjunct, particularly when starting dupilumab therapy. So to summarize, the addition of phototherapy can be beneficial in both psoriasis and atopic dermatitis, either as an add-on therapy to biologics or to accelerate response to those biologics. Obviously, adherence to the phototherapy schedule is key to its efficacy, and overall, this combination is a well-tolerated and safe option. The next adjunctive medicine is azathioprine. In psoriatic disease, the published literature regarding its use in combination is limited, but suggests that its incorporation could be beneficial. One study of 23 patients examined the long-term maintenance of infliximab when combined with either methotrexate or azathioprine, and the extended PASI scores are depicted in this figure. The azathioprine cohort was selected specifically due to an inability to tolerate methotrexate, and it should be noted that they were given a higher infliximab dose of 5 mg per kg per dose compared with the methotrexate cohort. However, their analysis did find that none of the azathioprine cohort had to discontinue therapy due to loss of clinical response to infliximab. An additional study comparing 500 IBD patients who developed an anti-TNF-associated cutaneous eruption found that the introduction of either azathioprine or 6-mercaptopurine at baseline decreased the risk of developing these eruptions. And you can see this cohort depicted here by the green line, which had the lowest incidence rates. In atopic dermatitis, this previously cited study found that there were no significant safety concerns when azathioprine was overlapped with dupilumab for, on average, about 7 weeks. Unfortunately, due to the sample size of this study, they were not able to do any analysis regarding differences in efficacy between the cohorts. So to review, azathioprine could be combined with TNFs, particularly in those patients unable to tolerate methotrexate. Although the literature is limited, published data suggests some benefit in both psoriatic disease and as a bridging therapy in atopic dermatitis. It may also help in preventing anti-TNF-associated eruptions. And finally, the safety data is small, but its frequent use in the IBD realm with TNFs suggests a degree of tolerable safety profile. So turning our attention to cyclosporin. In atopic dermatitis, its combined use with dupilumab has been shown to increase efficacy. In 69 patients whose atopic dermatitis was not adequately controlled on dupilumab alone, adding cyclosporin led to improvement in both clinical and symptom metrics, including, you can see the mean itch and sleep scores here. Additionally, as we often use cyclosporin as a bridging agent in dermatology when biologics are initiated, it should be reassuring that reports of its use overlapping with dupilumab have been well tolerated by patients. In psoriatic disease, cyclosporin has been used with anti-TNF therapies with good response, particularly for the cutaneous involvement. Interestingly, when methotrexate was compared with cyclosporin at 3 mg per kg per day as adjunctive agents in combination with etanercept, there was similar efficacy in their joint disease improvement, but cyclosporin was significantly better for skin involvement. A small study of 11 psoriasis patients confirmed this improvement in cutaneous response when cyclosporin was added to etanercept in patients for whom etanercept alone was insufficient. Similarly, as you see depicted in these figures, when cyclosporin at doses between 2.5 and 3.75 milligrams per kilogram per day was used in combination with adalimumab, there was a significant increase in both joints, which you can see here, as well as cutaneous improvement, seen here, compared with adalimumab alone. Overall, the studies reported no significant differences in serious adverse events, with a few reporting an expected increase in blood pressure in the cyclosporin cohorts. One additional patient population which may benefit from adding cyclosporin is those with TNF-induced psoriasis. In the previously described cohort, all patients who were given cyclosporin had improvement or resolution of their skin findings despite continuation of their anti-TNF. So to recap, the addition of cyclosporin can benefit both psoriatic disease patients, particularly those on anti-TNF therapies, as well as improve the skin findings in those who have developed TNF-induced psoriasis. It can also be used in atopic dermatitis, again, either as a bridging therapy or as an add-on to dupilumab. Admittedly, the safety data is somewhat limited by the duration of the studies published, but there were no unexpected side effects that were frequently reported. So switching to oral retinoids. The literature here is limited primarily to a few studies in psoriasis, but does appear to show some mild benefit when used in combination. Interestingly, 2 studies of around 120 patients in total were designed to compare etanercept at variable dosing schedules with etanercept combined with acitretin. The findings suggested that acitretin could be used as an equivalent adjunct in those patients for whom more frequent dosing of etanercept was not possible. You can see depicted here that both the PASI 50 and the PASI 75 scores were similar in patients on combination therapy versus more frequent etanercept dosing. And the lower line is acitretin monotherapy, which was significantly worse than either option. Additionally, an analysis looking at pooled data from multiple anti-TNFs found that the addition of acitretin allowed nearly 3/4 of the patients to discontinue phototherapy, which could be helpful for some of our patients in whom adherence to a strict phototherapy regimen is burdensome. Expected elevations in both LFTs and lipid profiles were seen, but fortunately no serious adverse events. So to summarize, acitretin may be beneficial in patients who are unable to obtain more frequent biologic dosing or in whom phototherapy is no longer feasible. Expected but mild lab abnormalities were seen in combination. Next up is dapsone. Again, the combination data here is somewhat small, and its added benefit appears overall to be mild. A study of 19 patients explored its use in stage 2 to 3 hidradenitis and found that the majority of patients who improved were on concomitant therapy, most frequently adalimumab. The overall time to response was about 2 months, and this combination was fortunately well tolerated by patients. So overall, while the data is limited, dapsone could be considered as an adjunct in patients already on biologic therapy for moderate to severe HS, and it may provide some degree of benefit without notable side effects or safety concerns. The last 2 combinations I will touch on rather quickly, as insurance and financial restrictions probably make their combination unlikely, but there is some data available for review. So first up, apremilast. Multiple studies do exist in psoriatic disease with somewhat variable results. An analysis of 14 patients who were demonstrating biologic fatigue had a significant decrease in their PASI scores with the addition of apremilast, and that seemed to stabilize by around 24 weeks. On the other hand, a retrospective review of nearly 150 patients found that there was no significant difference between biologic monotherapy and combination with apremilast. However, it should be noted that the combination cohort were patients who had more likely failed conventional therapies prior to enrollment in the review. Fortunately, an additional study of 22 psoriasis patients found that none had to discontinue due to intolerable side effects, and there were no safety concerns. So in summary, if insurance allows, this combination could be considered in psoriasis patients demonstrating waning biologic efficacy. Additionally, this combination appears to be tolerable, safe, and a sustainable option for patients. Lastly, looking at combined biologics. In psoriatic disease, the literature is limited to case reports and very small case series. And you can see in this table, which was published earlier this year, the entirety of the published data on combination biologics. Most patients had both joint and skin involvement, and the most commonly paired agents were ustekinumab and anti-TNFs. Overall, the reports suggested that these combinations were well tolerated, but there were multiple infections reported, and overall, the small sample size makes larger generalizations about their safety in combination difficult. In systemic lupus, there is more robust literature, although the findings are somewhat contradictory. 2 clinical trials have investigated the addition of belimumab to rituximab, with the larger analysis of nearly 300 patients finding no significant difference in disease control at 1 or 2 years. However, a sub-analysis did find a difference when looking specifically at patients with positive double-stranded DNA antibodies. This larger trial did find more serious adverse events in combination, while the smaller trial found that a safety check conducted between the 2 therapies was able to catch many infections before proceeding. Therefore, combination biologic therapy could be considered either in recalcitrant psoriatic disease and may be beneficial in systemic lupus patients, particularly those with double-stranded DNA antibodies. Additionally, when combining biologics, considering the increased infectious risk is paramount. So to conclude this whirlwind, adjunctive therapies can enhance efficacy and retention of biologics in many rheum derm diseases with generally expected and non-concerning side effects.